were the environmental factors?
UV light.
UV is the most important one. Gender, yeah, and
By drugs.
drugs. Drugs, which are the drugs and
Hyalazine.
yeah, isoniazid. Isoniazid is commonly used for patients with
This is an antibiotic.
anti-TB. Yeah. And what are the antibodies in drug-induced SLE? Antihistamine, yeah, antihistamine antibodies. INA, general INA, and antihistamine antibodies are positive in drug-induced SLE. And what are the two subtypes with cutaneous manifestations mostly?
What?
DLE has almost always cutaneous manifestation, and subacute cutaneous lupus erythematosus has mild systemic symptoms, and it is something between DLE and SLE. Yeah? Okay. The next disease is Sjogren's syndrome. In Sjogren's syndrome, what do we have? Dry eye, dry mouth. We have keratoconjunctivitis and xerostomy or xerostomy. And Sjogren's syndrome, what causes dry eye and dry mouth? Lack of tears, lack of saliva, enough saliva.
Something with the glands.
Yes, yes, exactly. Lacrimal gland and salivary gland. So the target for immune system are these glands. Yeah. And sometimes you have Sjogren's syndrome alone. It is called the primary form or Zika syndrome, and sometimes it's associated with other autoimmune disorders, mostly rheumatoid arthritis. Okay, so sometimes primary, sometimes secondary, most of the times the RA. Okay. In Sjogren's syndrome, you see what you see here, keratoconjunctivitis due to dry eye. Okay, and here you see dry mouth. It is lack of enough saliva causes dryness of tongue and other nasal surfaces, oral nasal surfaces. And in Sjogren's syndrome, morphologically you see infiltration of lymphocytes, which are both B lymphocytes, T helper cells, and plasma cells in salivary glands or lacrimal glands, and you will see some special kinds of autoantibodies. You will see antibodies against two ribonucleoprotein antigens, SSA or Rho and SSB or LA. Okay? And we also had SSA in lupus. Yeah? And so because we have SSA and SSB in other autoimmune diseases, these are not diagnostic for Sjogren. Okay? And in Sjogren, you may also see positive ANA, positive RF. Do you know what RF is? Rheumatoid factor. Rheumatoid factor, yeah, is mostly positive in RA, rheumatoid arthritis.
Is it also positive in lupus?
Lupus?
Yeah.
No, but it has.
Sometimes it's seropositive.
Sorry?
Sometimes it's
Sometimes yes, because it is not specific. It has many false positives. For example, in infections, other inflammations, and it is also positive sometimes in Sjogren's syndrome. Yes, maybe in lupus. In all all autoimmune diseases. It's not specific. And the pathogenesis, some, some references say that the primary and environmental factor is a viral infection. And then we have activation of T cells, T helper cells, and B cells, and we will have some plasma cells that start to produce autoantibodies, and we will have inflammation, and the last thing is fibrosis of salivary glands or lacrimal glands. Here you see swelling of salivary gland, and here you see dense infiltration of lymphocytes, and here you see a dot, salivary dot, which shows proliferation of epithelial cells. And the next disease is autoimmune. We talk about, I think it's better to talk about systemic sclerosis and then have a rest. Yeah? Good rest. Where can we find coffee here? There's no coffee. I'm sleepy. Can we find coffee here?
You have to go to the shops.
Coffee shop.
No, there's no shop there.
There's a
Oh,
shop.
outside.
Oh, yeah. We don't have a cafe here. We used to have it in the first time.
Yes. We talk about just three of them. We talk about SLE and sugar, and now we are going to talk about systemic sclerosis. As you can understand from its name, we have sclerosis in different organs. We have sclerosis in the skin, in, for example, lung, in different parts of the body. So, we have excessive fibrosis in multiple tissues, and we also have some kind of vasculitis, like many other autoimmune disorders. You will remember that we call autoimmune disorders, which are systemic collagen vascular disorders. Why? Because most of the times they affect vessels and connective tissue. We call them collagen vascular disorders. Sometimes this disease is limited to skin. We call it localized scleroderma. Okay, but sometimes it is systemic. Systemic sclerosis is categorized into two forms. Diffuse systemic sclerosis, which has widespread skin involvement, rapid progression to visceral involvement, and the progression to visceral involvement is early in the course of the disease. But limited systemic sclerosis, the skin involvement is mild, and most of the times it involves face and fingers, and involvement of viscera is milder and late. Okay, so the course is benign in contrast to diffuse systemic sclerosis. So we have localized sclerosis of the skin, scleroderma, which involves skin, and we have systemic sclerosis. Systemic sclerosis may be diffuse or limited. Okay? The limited form is also called CREST syndrome. And CREST, each letter is for the symptoms. For example, C for calcinosis, R for Raynaud phenomenon, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. You see it here. So we have in limited systemic sclerosis, we have calcinosis of different tissues, we have Raynaud phenomenon. Why do we have Raynaud phenomenon? And then, for example, our hands are in cold weather, they become, like this.
They become
the cause is the vascular damage because the vessels are narrowed and the circulation is not established well. Okay? And when there is cold weather and we have constriction of vessels, there will be no more circulation and the fingers become pale. Okay? So we have Raynaud phenomenon, we have esophageal dysmotility because we have fibrosis in esophageal wall. We have sclerodactyly, which means that this deformity of fingers, and you also may see telangiectasias on different parts of, for example, the skin. And here you see Raynaud phenomenon, and this is sclerodactyly. Here you see, let me show you. You see some, there are
Redness.
some ulcers because of poor circulation on the arterial parts. For example, I have the picture on here. You see sclerodactyly and you see some ulcers here. And okay, so in systemic sclerosis, you have autoimmunity, and the two most important parts are vascular damage and collagen deposition. Okay, about autoimmunity, do you remember inflammation part? Inflammation, about fibrosis, about macrophages, which could be activated in a classic, pathway, or alternatively activated macrophages, which cause fibrosis. In scleroderma or systemic sclerosis, we have CD4 positive T cells, mainly T helper 2, which cause by producing interleukin 13 or activating macrophages and producing TGF-beta cause fibrosis. Okay, so the most important thing is production of fibrosing cytokines and fibrosis of different tissues. And as you see here, like many other autoimmune disorders, the antigen is unidentified. The trigger, the antigen is not identified. For example, in lupus, we said maybe, for example, due to uvuli, and the antigen is nuclear antigen, but the main cause is not yet found. And in children, we have viral diseases, but here we have no hypothesis. And we also have vascular damage. Vascular damage, for example, we have vascular narrowing by, endothelial proliferation and fibrosis of intima and perivascular tissue. And we have this in pulmonary vessels. And so we have pulmonary hypertension, which is very important in these patients in systemic sclerosis. And we also have fibrosis, not only because of fibrogenic cytokines, but also because we have hyperresponsiveness of fibroblasts to those cytokines. And also because we have vasculopathy and ischemia, and following ischemia, we always have fibrosis. So we have cytokines, we have hyperresponsiveness of fibroblasts to those cytokines, and we have ischemia, which leads to fibrosis. And here in this picture, you see the pathogenesis of systemic sclerosis. As I told you, we have, because of unknown reasons, endothelial injury, we have proliferation and obliteration of vessels, and we have, for example, pulmonary hypertension due to this, and we We also have ischemia due to obliteration of vessels, and after ischemia we have repair and fibrosis. And we also have autoimmunity both in T and B cells. We have autoantibodies, and we have production of some profibrotic cytokines by, for example, macrophages, or by, for example, T helper 2 cells which activate macrophages, and we will have increased synthesis of extracellular matrix, and we have fibrosis. So, the important thing in systemic sclerosis is fibrosis. Okay, look at this picture. I told you that an important organ that is involved is the skin. Can you compare these two pictures? This one and this one. We have epidermis, dermis, and subcutaneous fat. Okay, this is normal skin. Okay, compared to this, you see here increased thickness of dermis. Okay, and you see that the collagen fibers are thick here, and they have been trapped in the sweet gland. Yeah, and you see, compare the thickness of collagen fibers here and here. So we have more collagen, thick collagen, and this is what we see in skin sclerosis due to, for example, scleroderma or systemic sclerosis. And here you see, I showed you the picture. What is this? What do we call this? Scleroduct. Scleroductivity means, this claw-like appearance of fingers because of, the sclerosis, the fibrosis of connective tissue and skin. And as I told you, because of, vasculopathy, we may have ulcers. Yeah? So, tell me about Sjogren's syndrome. What did we see in Sjogren's syndrome? Sika.
Dry eye.
Dry mouth. And
And comes secondary or alone.
yes, the primary form is called Sika syndrome. Secondary form may be seen in coexisting with different autoimmune diseases, but the most common one is RA or rheumatoid arthritis. Yeah, and what antibodies are present in Sjogren's syndrome? As
SSA.
yes, SSA, RAW,
SSB.
SSB, LUC. And we may also have RF positive, INA positive, and also these two antibodies are not specific and diagnostic for Sjogren's syndrome. Okay, and in Sjogren's syndrome, we said that we have both T cells, T helper cells, B cells, plasma cells. They infiltrate the salivary glands, lacrimal glands. Yes, yeah. And about sclerosis, scleroderma, we said that we have limited systemic sclerosis or CREST syndrome and diffuse, and we also have scleroderma localized, which only involves skin. And what was the difference between CREST syndrome and diffuse systemic sclerosis? In CREST syndrome, involvement of skin was mild and localized, and we had mostly involvement of skin of face and fingers, and also we had milder systemic involvement later, and the course was benign. But in diffuse systemic sclerosis, widespread skin involvement, and very soon we will have severe systemic symptoms. And in CREST, we had calcinosis, renal and esophageal dysmotility, and we have crest sclerodactyly and telangiectasia. Okay, and we said that in all of the diseases in this category, we have the most important thing is fibrosis. Yes, for example, because of ischemia, we have fibrosis. Why do we have ischemia? Because of proliferation of endothelial cells and intimal fibrosis, and we have some kind of obliteration in vessels, and we have ischemia, and after that we have fibrosis. Or we may have activation of M2 macrophages alternative pathway, and we will have production of fibrogenic cytokines, for example TGF-beta, and we will have fibrosis. So that was the mechanism of these disorders, which in all of them we have sclerosis. Okay, you can have some rest, and I will see you